Thank you very much, Dr. SPS Grewal, for giving me this opportunity. As you rightly said that majority of the patient in our country, they delay cataract surgery uh, because they are finding better to read for near, they become more myopic, and these hard cataract particularly, many of them, they induced myopia also. But when it comes to surgeon, they find much more problem to deal with them. I will be speaking on how to crack the hardest one, pulse of wisdom. What are the challenges in performing phaco surgery on black or brunescent cataract? Since there may be poor red reflex, capsulorhexis is much more difficult to perform. High phaco energy. Actually, these hard cataract may need high phaco energy, and corneal endothelial damage more likely to occur in these patients. Leathery hard nucleus, they resist fragmentation during chopping. Chopping is much more difficult, whether it is a direct chop or whether it is a stop and chop. It is much more difficult to perform in these cases. And then emulsification, more energy is required. There are much more higher chances of posterior capsular tear compared to other cases of cataract. More zonular stress and much more risk of subluxation. There are increased chances of iris chafing. Some of the pre-operative consideration, we have to see each of the patient very carefully, and we have to dilate the pupil of each of the patient to see how much dilatation of the pupil is achieved, whether it is adequate dilatation or whether we will need iris hooks or ring to adequately dilate the pupil. We have to also see for endothelial cell count. If clinical examination showed that endothelium, there is corneal guttata, in that situation, surely I think you should go for corneal endothelial cell count. Then we decide whether we can do phacoemulsification or whether small incision cataract surgery is good for this patient, or sometime one should not even hesitate to do extracapsular cataract surgery. I think you should not have ego that I want to do phaco only. And then whether bag is stable or what is required, whether phaco or small incision cataract surgery. Of course, many of these patients, they need ultrasound B scan if it is much more hard and fundus view is not visible. And then we have to have with us a single piece. Most of the time we keep, but sometime or many times multiple piece, 3-piece IOL. Sound. This is a very hard cataract. This is white in color, but we were knowing that this is a brunescent cataract. And here, anterior capsule is stained with trypan blue dye. Hydrodissection done. And ultimately stop and chop, and then separation of the nucleus, and then multiple fragmentation, and particularly one has to be very careful each time when we take out the last piece of the nucleus. We have to reduce the power and the energy and parameters. So here capsular bag is filled with viscoelastic. is removed from the bag, and then rock hard cataract or brown cataract, very poor glow. Stain the capsule with tryptophan blue dye. We might use sharp blade chopper. Viscoelastic is repeatedly put into anterior chamber to coat the endothelium. And parameter is set for particularly hard cataract. Once we know it is very, very hard cataract, it may need more than 50% power. Here in this case it is 70%, or it may vary with the density of the cataract. So all the parameters, they may vary. Most of the time we try that whether we can do direct chop, but many times we fail. Then we try to do stop and chop. But here we succeeded in chopping fragmenting it into two half. Then stop and chop. Stop and chop is done most of the time, because when we do stop and chop, we make a groove, and little wider groove, and this gives a space. While you fracture the nucleus, it gives a lot of space. And once you take out even a single piece of the nucleus, then I think it is not difficult to remove the cortical material. Then comes very, very leathery cataract or very, very hard cataract. This is a jet black cataract. Attempt was done to do direct chop. It may be difficult, but then one may not struggle. Then one may do stop and chop. And viscoelastic is put, repeated viscoelastic, because we don't want to damage corneal endothelium. Despite putting very, very high power, 70% or even 75 to 80%, it may be difficult to emulsify. And then, of course, while it is the last piece, we should take precaution. We have to be a bit slow, and in all these patients, I think patience is the key to success. Then comes a patient with the hard nucleus and small pupil. It is a double challenge, and you have to be prepared in such patient, in all the cases, that you should be ready with the Malaysian ring or iris hooks. But here we thought that we will try that whether pupil comes down or not. Already it is a small. And rhexis, it should be larger rhexis in these cases compared to the other cases. So here it is done behind the iris without much visualization, but with experience. But it was found that it was very, very hard cataract, and even increased power was not doing much to do even the trenching in this case. So it has, pupil has come down, pupil has become small. Viscoelastic injected, and then I planned that okay, I will apply iris hooks. Actually this trench, because direct job was not possible here, and this trench was made, and this will give adequate space when it is fractured into two parts. And you have to have patience, and you have to be slow also, because it is better to make multiple pieces of each of the nucleus. While you take out one small piece of the nucleus, it gives a good space for the nucleus to move. And then each of the piece, if you make 4, you have to make then 8. Each of the small piece you have to divide into 2, and further smaller piece. So here I think a lot of patience is required to deal with such patients. And viscoelastic is good. And then cortex is removed from the capsular bag. And then implantation of IOL into capsular bag. Once I think capsular bag is intact, you can use any type of IOL. Most of the time recently we use a single piece IOL, but most of the time we keep 3-piece IOL for such patient, because and then comes this is one of the patient with rocky hard cataract with corneal astigmatism, and patient was also not cooperative even for marking. This patient has 3.39 diopter of astigmatism. This SN689, this IOL, this is Alcon IOL, this was selected. And then what challenges were expected? Damage to corneal endothelium, runaway rhexis. These are the common thing which happens in these cases, or even then rhexis become difficult in these cases, but here it was done. A larger rhexis was done in this case. I think rotation is very important. Once you do hydrodissection, rotation is very important, because you become much more confident. And if you do direct chop or stop and chop, I think this gives a much more confidence to surgeon that okay, I am succeeding. And of course you have to put viscoelastic in between and fracture each of the nucleus piece into many of them, because if it is a half nucleus or so, it will touch the endothelium, more damage occur in such patients. So it is better that most of the time, or mostly one must do phacoemulsification in the capsular bag. And here I am trying to make multiple pieces. And this is jet black nucleus, and you can see that there is a lot of good relief while you see the red glow. A lot of patience is required to remove these nuclear pieces. And finally, the last piece of the nucleus is ready to be removed, and here it is absolutely jet black nucleus. And then last piece. And sometimes these cases you may, even small piece may hide somewhere behind the iris or in the angle, and on the first day it may come into anterior chamber. That may be usual story in these cases. And here we are implanting single piece toric IOL. Callisto is used, although marking was also done before because then you have to remove the viscoelastic from front and behind the nucleus. And then come many of the complications which may occur in these cases. It looks good. It looks that there is a very good red glow. But this is again brunescent cataract. No rupture of the posterior capsule. You can see here what is happening. I had the feeling that something wrong is there. And here nucleus is gone. So you may do 99% good, successful this, but you have to be ready for this. Here, you remove, you don't hunt the nucleus. Best is just let it go. Remove the cortex. Do anterior vitrectomy and implant IOL in the sulcus. And because why I place suture? Because retinal surgeon is going to remove the nucleus afterward. These iris hooks were placed by the retinal surgeon and removed the nucleus in the same sitting. Then sometimes you may need IOL scaffold. This is again very hard cataract. Lot of viscoelastic repeatedly placed into anterior chamber. And here I realize that there may be PCR. Then I planned that I will not remove this nucleus piece. I will first implant IOL into sulcus, and then remove the nuclear piece, whatever residual nuclear piece is there. So IOL was placed in the sulcus and this nucleus was removed. One of the heptip is still outside in the, but it is placed into sulcus, and so this scaffold technique helped to prevent further dropping of the nucleus and further complication. You may get some of the other complications, such as here. This is iris shaping here in a black cataract, and then this is after completion of the case. There may be lot of edema along the side port. Despite or taking all the precaution, you may have Descemet's membrane detachment here. This is a small Descemet's membrane detachment. So newer technology such as femto laser, which Dr. SPS Grewal will be explaining in detail. Surely I think it helps, particularly in these black cataract. There may be JEPTO or manual CCC or whether you use submarine chopper or other thing, or this Dr. Sartaj will be discussing the my loop and beyond. This I will not speak much about it, but maybe small part of the video, such as definitely I think this make the job much easier. Capsulotomy and nucleotomy here done with Pemeto, it become already it is a chopped one, but then it chopping become easier, and phaco power and energy required will be much less, and it take less time also. So one should not think that technology is a failure. Technology definitely help in case to case basis. This is 1.5 diopter IOL. This is a case of eye myopia, and this IOL is not available in single piece. 1.5 diopter. They are available in some of this Alcon and J&J sensor AR40. So then take home message. Pre-operative assessment is extremely important. We have to note what is the density of the cataract. We have what dilatation of the pupil is achieved, zonular status, endothelial cell count, particularly where there is a cornea guttata, or otherwise also it may damage in these cases. Staining of the anterior capsule using trypan blue dye in jet blue cataract, jet black cataract, larger CCC, and we have to ensure rotation of the nucleus. Keep using viscoelastic substance, dispersive viscoelastic to protect the endothelium. Always have a backup plan, CTR, pupillary expanding devices, even 3-piece IOL. And lastly, do not lose patience. I think patience is the key to success. But you should not have ego if you have to convert it into extracapsular cataract surgery. I think that ego should not be there with you, because patient want vision. If it is a dropped nucleus or if there is a white cornea, I think it is better to do ECG. Thank you very much.
Thank you, Professor Jagatram, for captivating and mesmerizing videos. Now it's open to questions as well as comments, and anyone who would like to share their experiences in handling these cases. Can you please keep the mics ready for the audience? Anyone who would like to make a comment, ask a question, or add anything to it? So, out of the videos that Sir has shown, one
we make a call whether to go for SICS or FICO, like depending upon the skill that I understand, but also like where do we make a line, like how do we fill a boundary that this case should be better to perform an SICS or FICO emulsification, like is there any ocular comorbidity coexisting, that's the only defining criteria, or there is some specific set rules, or is it individualized and like?
I think this you have to assess from case to case. If it is a black cataract, and such as I was confident, okay, I did started with FICO. But if you thought that, you know, lot of FICO power is used, nothing is happening, you cannot chop it, you cannot do FICO much more, you can convert it into extracapsular cataract surgery. You can extend it both way. Or initially, if you are not confident that, okay, I will fail, then from the very beginning, that will be much better. If it is from the very beginning, that is the best. You decide that whether you want to do phaco or you want to do small incision cataract surgery, because that will be the best.
Also
In
depends upon the
these
expectation of the
patient, we explain in the consent that your cataract is very, very hard, your recovery will be delayed. Don't give a rosy picture that no, no, you will be 6 by 6 first day. You have to tell that your corneal swelling will occur. You give even hypersol to these patients. But if it is better to decide before surgery if endothelial cell count is low. It is better that small incision cataract surgery or extracapsular will be better, because there you are taking out the nucleus. Little loss will happen, but in phaco much more loss will happen. So I think you have to decide. If your experience is so much thousands or even several thousand of patients, then you have to decide whatever your heart say that you have to do this.
Yeah, I think
Thank you.
it'll be whatever works better in your hands. If you're more comfortable with FACO, you'll find ways to manage. There are tools available for that. But if you're more comfortable with SICS would be a better job. It's less stressful.
You mentioned, you were about to mention something about patients' expectations. I think patients' expectations should not influence the decision of the surgeon. What matters here will be your past experience with similar cases and your results in similar cases, which will decide what procedure you take. And out of the ocular parameters, the endothelial cell count. If you already know, as sir mentioned, that endothelial cell count is low, right from the beginning, plan for extra. No, at the last, yes, please.
Sir, what was the benefit of keeping the cortical matter and placing the IOL in?
No, that was a case where we suspected that there was a large nuclear piece superiorly entrapped in the ruptured, it was entrapped. So because while doing removing and doing phaco of that piece, it may go down. So it is better that you implant IOL and bring this piece over to the IOL scaffold, and then easily you are 100% sure that it will now not go down, because you have implanted IOL in the sulcus and removed the nucleus from over. Otherwise, it may go down. Definitely there was a tear, posterior capsular tear. Posterior capsular?
Posterior polar cataract.
Yeah, posterior polar cataract.
Yeah.
I think excellent. In these cases, if it is a brown cataract, you may not even know that it is a posterior polar cataract. But each case has to be dilated and has to be seen. And you may not do hydro dissection completely, you do limited hydro dissection. And you must be ready with the hooks or other modalities, even 3-piece IOL. So you have to be much more careful in such patients. Such as one of the patient, there was a drop. It was not, we never suspected that it is a posterior polar cataract. So in brown or brunescent cataract or black cataract, there can be possibility, although rare.
Generally, PPCs are developmental, so they present early. So mostly the sclerosis is less, so we get it diagnosed. But until and unless one eye is operated, the other eye may come with NS2 to 3. Then we have to.
Yeah.
Thank you. Yeah, I just wanted to make a comment about the small pupil hard cataract case with the iris hooks. So I've never, regretted putting in iris hooks in those cases. early, right at the beginning, just because, not that you can do the case without the hooks, but if the pupil comes down, then putting in the iris hooks, it's much more likely that you could catch the capsule edge.
Yeah, even if initially you have preoperatively, we write that what is the maximum dilatation of pupil, it may be fine. Pseudo exfoliation patient, initially it may be fine, but later on during surgery it may go down. But we are ready with the iris hooks or Malaysian ring or any Bhattacharya ring, any of these modalities. So one has to be prepared, mentally prepared in advance, mostly. But sometime if we are not prepared, then at the time of surgery we have to take a call that this is the issue, how it has to be managed.
Is there any role of P-chopping in heart cataract?
Yeah, chopping definitely. Best is many of the patients we succeed in direct chop, but in many of the cases we make a groove and make a good space and fracture the nucleus, and then multiple that is stop and chop, do chopping of the fragments.
Was the question about pre-chop?
Yes, sir.
The nucleus is so hard, it will be very difficult to put anything into it that's where the my loop role comes, which will come at the end of the session. Pre-chop in a very hard nucleus is very difficult to do.
So what are few tips to do a better direct chop in such cases, like for a better hold in?
I think if it is a moderate type of moderate density of cataract, you can do direct chop most of the time. If it is a black cataract, jet black cataract, you may not succeed many times.
Mostly you would need a sharper chopper. You would need reasonably high vacuum parameters to get a nice hold. Make sure you go far enough with the chopper under the capsule, and be prepared to sort of chop it at multiple levels. Don't let go too early. Don't like NS2, NS3, they're brittle. They'll crack quite easily. Here you really have to keep holding on to it and pull it apart.
All the depth
Sir,
of it.
It's also
Okay, thank you.
it's also important to understand the physics of the forces acting between the tip of the chopper and the tip of your phaco probe. Your movement should be such that there are not much tangential, otherwise it will start rotating like this. So a good hold, that means when you go first time, you should go deep enough to have a good hold, and then your chopper should be such that it only comes in this direction. Movement like this and like this is to be avoided. So it's basically interplay of forces and keeping them in a direction so that you don't lose the hold. As long as you have a hold, you will be able to chop.
Sir, I have a question, please. Excellent videos. Just one question. A lot of these brown cataracts occupy the full bag. So when we're doing this direct chop, and there is a lot of stress on zonules, especially for people who are learning phaco. So would you recommend to do direct chop, or would you ask them to do a good debulking prior to proceeding with the chop?
You are right. I think you are much more right, and the answer of your question is the second part. Initially, for the beginner, it is better to do debulking. It is better to do stop and chop. What is stop and chop? We make a groove. In these cases, we make larger groove and separate fracture. And then making it 4 pieces, 8 pieces are much more easier. But doing direct chop for the beginner is much more difficult. This is my opinion. It may differ, but mostly I think stop and chop for the beginner is better than direct chop, particularly for hard cataract.
Okay, thank you.
I think that's a very good comment, and even if I am doing flax and it's a hard cataract, I would still like to debulk for the same reason that you have said, that you have space to work around. And in these cases, two things which are very important, as has been mentioned, is the first divide and the first chop. If you have divided the nucleus into two, irrespective of how hard it is, you have won 50% of the battle. And if you have able to remove the first fragment, that means now all you need is, as he said, patience and perseverance, and you will be able to complete the surgery. Any other comments before I sum up the...
There are some mentions of ultrasonic pre-chopper in hard cataracts. Do you have any experience about it, or anybody in the audience has any experience about it? Ultrasonic pre-chopper or ultra chopper?
We don't have experience of ultrasound chopper or ultrasonic chopper, but I think it may be good for not very extremely dense cataract, but since I am not sure because I have not done. So
It's
we don't-
relatively new. It looks very interesting, and kudos to innovation. It's always amazing. My fear is I mean, like I use the MyLoop a lot, and I just feel the MyLoop seems safer and easier because I mean there'll be some logistics also with the ultrasound chopper that then you remove it, you switch back to your ultrasound probe, or you keep two machines. But it is excellent. There's no doubt. And the videos that I've seen, it'll cut through anything. But that's also a fear that you don't want it cutting through anything you don't want it cutting through. So yeah, seems, but it'll do the trick. Why not?
Sir, I have a small question. Considering hard cataracts black, say you said black cataract, sir. So what may be the post-operative outcome between SICS and doing phaco?
I think if you can safely do phacoemulsification, it is fine. But otherwise, if it is absolutely jet black cataract, if cornea become white,
No, sir,
nucleus
that
is
is not the
dislocated.
question, sir.
So
Question is what is
outcome may be better in small incision cataract surgery or even ECC if we expect that much more complication or much more endothelial damage will take place. I think outcome may be better in the initial planning of extracapsular or even small incision cataract surgery.
So in black cataracts, it should be indicated that you should do an SICS rather than phaco if the complications are
No,
lower.
it is a experience of the person. We have done phacoemulsification, we have done small incision cataract surgery also. We also convert to such modalities.
Question is very specific, sir. Post-operative outcome.
Okay, can
In
I?
the right
I'll
hands, it'll be the
answer-
same outcome.
Okay, I'll answer it differently. One, in a hard nucleus is so big, 6 is not going to be easy. Now you have a choice. You have a choice to have a clear cornea on day 1 in ECCE and astigmatism changing and refraction changing over the next 2 months versus a hazy cornea and poor vision for a week, but better results in the long term. So this is where you will weigh between your experience and your competency to decide what you're going to do.
Okay, sir, thank you.
So there was mentioned that red glow can be erroneous sometimes. That was a nice video. It is only when you touch the nucleus that you find there is some issue. The change in plan has been beautifully demonstrated in the videos. One point he mentioned, I would like to re-emphasize, is about the hidden pieces. In these cases, small piece sometimes goes, and with the fluidics, it goes so fast under the iris and between the iris and the capsule, you can't find it. So what I follow the strategy in these cases that when I have a fragment, I'll remove it completely, then go on to the next fragment. There is always a temptation, I have removed most of it, let me go on to the second fragment. So in these hard cases, first fragment, whatever its remnants are, clear completely and then go on to the next one. It's also important to understand what is happening at the tip between the aspiration and between the flow. Many times we'll be trying to get these pieces to the tip with the help of imagining that it is the aspiration which is going to pull it. No, it is you need to be always clear about in your mind that what are the fluidic movement taking place in the anterior chamber, and you should use the irrigation flow to redirect the fragments onto the tip of the phaco tip so that it's engaged easily. Handling of the complications has been shown beautifully, and last is that be friends with the retina surgeon.
I think important is that you don't hunt the nucleus. In a case where there was a drop of the nucleus, without knowing much fault of, I did that case, but it went down. So I left it, placed the IOL in the sulcus, and my retinal surgeon, I think Dr. Anjani is here. She did excellent job, I think same day. Your retinal surgeon should be ready to do the job, and you have to tell the patient. You should be very confident and telling the patient that your nucleus has dropped. I told patient that, but patient was very confident. Doctor Sahab, whatever you do, and patient had excellent outcome.